was great to see you at the team meeting yesterday. I think everybody was really interested to hear the process that happens. I don't think they appreciated it for getting our EoE patients some of these newer and targeted therapies. And just remind me, once the decision is made, say to give somebody, say a biologic, how do you handle that? What do you do next?
Right, so I look through the records, first of all, to just kind of understand what's been going on with the patient, what other therapies they've tried and failed or maybe didn't tolerate. Kind of note where those records are. Since we have a team of pharmacy technicians that help us submit some of these authorizations, I tend to write a summary note and point those pieces out to them so that they understand which records we should send on to the insurance plan when we ask for these medications. And then I'll submit the request for the prior authorization and track it through, kind of watching for those, denials or anything that we need to, address with bumps in the road.
Yeah, and I think it's helpful for the patients and even our referring providers to know that most of the time these just get denied outright. And that's sort of the expectation at this point, and then we have to go through that prior authorization process and sometimes the appeal process. And how do you figure out actually where to even send the prescription, something as basic as that?
There are certain insurance plans that very clearly link their pharmacy benefit manager when you pull up their active pharmacy insurance. And so, if the pharmacy benefit manager is OptumRx, that prescription may go to Optum Pharmacy, or if it's Caremark, it may go to CVS Specialty Pharmacy. But also our pharmacy team can often do a benefits investigation for us and help us understand which one is the best pharmacy to send this to. Sometimes the patients know.
Right. And then we usually, we'll get the denial, and I think it's been an interesting process, let's say learning over time kind of how to compile the clinical information in a way that the pharmacy and the prior auth people can understand it. And so we do have some templates that can be helpful, I think, for doing that.
I work with about 7 different providers from the esophageal group in our GI practice. And I answer calls from the patients that see all of those providers, answering health questions. I do some education around medications, assist with refill needs, answering questions, and certainly get pulled into challenges around getting medications, often involving insurance. Now that there are some biologics approved for EoE, we are a little bit more involved in the insurance approval process. So when one of these biologics is prescribed by our doctors, I'll go back and look at their documentation often in their first clinic visit. The gastroenterologist has really reviewed past endoscopy results, tried and failed medications, various therapies and diets that they've been on in the past. So I can look through and see what would support some of those insurance, key marks that I know they're looking for to support approval. And I'll pull those together for our insurance team or submit the prior authorization. Hey, this is Kim in Dr. Dillon's office. I was calling to see. Yeah, I think what we've found is really that if you put all of the information in one place and make it very simple for the insurance reviewers who are doing this very quickly to see the tried and failed medications, the symptoms of ongoing dysphagia or needing to adjust eating habits, and putting all of that information into one place can be really helpful versus sending 85 pages of past medical records. They're not going to look through it and they will miss tried and failed medications and deny the medicine for it.
Yeah, and even simple things, it turns out that abbreviations don't usually translate, and so you've got to write out the full words and all that kind of
absolutely.
stuff.
Good point.
Yeah, and then, so say the prior authorization is denied, how do you go through the appeal process?
So I first look at the specific denial letter for the reason for denial. Sometimes they didn't see a tried and failed medication, so I will make sure that we had the records for that. Sometimes for commercial insurance, we can actually call the pharmacy benefit manager and without appealing, just kind of ask them, what are the options here to discuss this denial? And sometimes they'll let us submit additional clinical information without having to go through the appeal and overturn their initial denial decision. So in that case, if maybe a record was left off and not sent in, they'll let us do that. Certainly if we have to write the appeal letter, we use some templates, right, to summarize some of the known data, to address reasons for denial around, tried and failed medications. And I think, you don't have to try all of these medications for 2 years from an insurance plan's perspective. They might not have tolerated it. It might have been a terrible burning sensation in their throat or something like that that caused a patient to not be able to take this medication, and that counts as a failure in terms of insurance. So they'll usually accept things like that if we can gather the information.
Yeah, no, I think that's a great point. And if people haven't tolerated the medicines, that's the same as if they took it and didn't respond from the standpoint of the appeals. And I think the letter templates are useful because that way you don't have to reinvent the wheel every single time. But it also helps, I think, to summarize the indication and the evidence base and sort of the rationale for using these meds.
I think it's a nice opportunity to share the patient's experience with this EoE and how it's impacted their life. And dysphagia, sometimes they've had transient food impactions, things that have sent them to the ER, and really troublesome symptoms that we can point out in evidence to build the case for appeal. Hey, this is Kim in Dr. Dillon's office. I was calling to see how you're doing with your EoE. Is this a good time to talk? So I can see that you've been to clinic most recently about 6 months ago, and so I just wanted to check in with you and see how things are going now. How have you been generally doing with your swallowing? Good. And how are the injections going? So no irritation or kind of redness at the sites when you inject? Okay, well that's great.
And how do you track all this stuff? Because we have a lot of patients on a lot of different meds, and how does that work?
For our specialty medications or things that are harder to get insurance approval for, we have a spreadsheet of about 200 patients now that are on these various biologic medications in terms of what medication they're on, where their pharmacy is, and when their prior authorizations expire, so that I can track upcoming expiration dates, make sure that we have documentation to continue if it's still going well for the patient. I check in with the patient if I haven't heard from them in a little while and make sure they're still doing okay with it. So I can stay on top of these insurance approvals.
Well, that's terrific. I mean, it's a lot of work, and my sense is that in general, just the persistence is needed to, the goal is to take care of the patients and get them the treatment that we think they need. And it makes such a difference to them once this work is successful and it gets approved. And you've seen patients and patients like Max who've done really not well for a long time, and then can get on a newer med, and it can be life-changing for them in a great way.
Yeah, absolutely. So if we can summarize it and get it all in one spot for insurance to see, we can get these things approved. You just have to go through the multiple layers of process, which can be frustrating sometimes, but is doable.
Yeah, no, very frustrating. And I think, now that you've done this a lot, the first denial is not really a denial. It's just what happens, and then you expect to go to that second step. And I think it's that ongoing persistence that'll get the patients what they need to maximize their care.
Yeah, I do try and point out to patients, and there may be bumps in the road with insurance with some of these medications, and to please let me know if they're not able to get what they need from their pharmacy. Some patients have a tendency to just, well, I'll tell the doctor at the next clinic visit, and they don't share that they haven't been able to get the medicine the whole time. So. Just intentionally pointing out that there are barriers and there are some challenges with this, so please reach out.
Yeah, no, that's great. And the way you have the open communication is so valuable to the patients, because if they are not taking their med and then they just happen to come for an endoscopy or something, that's not a useful procedure for them. And you hate to do a procedure on someone who's not on the medicine that they should be on. And so I know that they very much appreciate that kind of communication.
It's been great, honestly. Again, having that kind of network of doctors, in terms of getting references from one to the other, but also their communication with each other and with me has just been amazing. My allergist, my GI doctor, Dr. Dillon, just all these people have been so on top of it, which has been great.